this great set of sources, all these notes about a condition called subacute thyroiditis. It sounds like it could be pretty baffling.
It definitely can be. And it's got that very distinct signature. As you said, your source material is really rich with detail.
So our mission here is to kind of sift through all that, pull out the really crucial bits.
Exactly. We want to give you a clear understanding of what this thing is, subacute thyroiditis. Why it starts, what it feels like.
How doctors figure it out, and then how it's generally managed.
Think of it as us navigating your notes together. Just highlighting the absolute must-knows about this, well, often quite painful thyroid condition.
Okay, sounds good. Let's start right at the beginning then. What actually is subacute thyroiditis? What's the core idea?
So the sources define it as an inflammatory disorder of the thyroid gland. And crucially, it's self-limiting.
Self-limiting. Okay, so that means it's inflammation, but it kind of burns itself out. It gets better on its own eventually.
Precisely. It runs its course over, weeks or months usually.
And I noticed in the notes, it seems to have a few different names floating around.
Ah, yes. You might see it called de quervain's thyroiditis, sometimes granulomatous thyroiditis.
Or even viral thyroiditis. That last one gives a bit of a clue, maybe.
It does. They all point to the same underlying condition, though, just different labels you might encounter.
Got it. So what makes it distinct? What are those defining features that set it apart from, say, other thyroid issues?
Based on the material, the big things are, 1, that painful swelling or enlargement of the thyroid.
Right, the neck pain we started with.
2, that kind of roller coaster of thyroid hormone levels. It's transient, meaning temporary. It usually starts with too much hormone, hyperthyroidism.
Feeling wired, maybe losing weight.
Exactly. And then it swings the other way into hypothyroidism, not enough hormone.
Feeling sluggish, tired.
Mm-hmm. And the third key feature is what we just mentioned, is self-limiting. It typically resolves.
So that pattern, pain, then hyper, then hypo, then hopefully back to normal. That's the classic picture.
That's a really characteristic sequence, yes.
Yes.
And the pain is often what people remember most vividly.
Okay, so that leads us to the why. Why does this happen? The sources seemed pretty clear about a common trigger.
They really do. The etiology, the cause, is strongly linked to a preceding viral infection.
So like after you've had the flu or a bad cold?
Yeah, the notes list specifics. Coxsackie virus, mumps, influenza, adenovirus, even EBV, the Epstein-Barr virus.
Interesting. So you get sick, you get better from that, and then maybe a few weeks down the line, bang, this neck pain and thyroid thing kicks off.
That's often the timeline, yes. And what's really fascinating, pathologically speaking,
Go on.
it's usually not the virus itself directly attacking the thyroid at that moment. It's more about the body's reaction after the infection.
Ah, okay. And I saw something else interesting in the sources, a potential genetic factor,
Yes. There's a noted association with something called HLA-B35.
which suggests what? That some people might just be more prone to reacting this way after a virus.
Exactly. It implies a genetic susceptibility, perhaps making their immune system more likely to target the thyroid in response to certain common viruses.
Okay, so let's unpack how that reaction unfolds. The pathogenesis. The sources say the virus triggers an immune response, but it gets misdirected.
That's the idea. The immune system gets revved up to fight the virus, but then it mistakenly starts attacking components within the thyroid gland itself. It's an immune-mediated inflammation.
Right. The body's defense system turns on itself, basically.
Like,
Temporarily.
Temporarily, usually. And this inflammation, this attack, it causes physical damage. It destroys the thyroid follicles.
Follicles. Those are like the little storage sacs for thyroid hormone, T3 and T4.
Exactly. Think of them like tiny warehouses full of hormone. When the walls get damaged by the inflammation, all that stored hormone just spills out into the bloodstream.
Ah. And that's the sudden rush that causes the initial hyperthyroid phase.
Precisely. That's why you get those symptoms. The palpitations, feeling hot, losing weight, maybe anxiety or tremors. Too much hormone all at once.
And meanwhile, that ongoing attack inside the gland, that's causing the actual physical pain and swelling in the neck.
Yes, that's the local effect of the inflammation right there in the thyroid tissue.
Okay, but if the storage sacs, the follicles, are damaged, they can't keep making and holding onto hormone properly.
Right. So once that initial spilled supply of stored hormone is used up, and because the follicles are damaged and inflamed, the gland can't produce enough new hormone to keep up.
And that leads to the next phase.
The hypothyroid phase. Hormone levels drop too low. That's when you might feel fatigued, gain weight, feel cold.
And then hopefully,
And in most cases, the inflammation subsides, the thyroid tissue heals, the follicles repair themselves, and normal function returns. That's the recovery phase.
So, putting it all together, it's really the body's immune response after a virus that causes the trouble. An overreaction almost that temporarily messes with the thyroid.
That's a great way to put it. It's less about an active infection in the thyroid and more about the inflammatory aftermath.
That makes a lot more sense. Okay, let's shift gears to what it actually feels like for someone, the clinical picture.
Well, the absolute number one symptom, the hallmark, is that thyroid pain.
In the neck, yeah.
Your sources emphasize it's often sudden, pretty severe, and crucially, it can radiate
Radiate where?
up towards the jaw or sometimes the ear. That pattern of radiation is quite suggestive.
Wow, that sounds like it would really get your attention. And you mentioned feeling generally unwell, too.
Yes, often accompanied by systemic symptoms like fever, just feeling run down, malaise, like you have the flu, basically.
Which ties back to the inflammation and the viral trigger again.
Exactly. And then layered on top of that are the symptoms specific to the thyroid hormone levels, depending on which phase you're in.
So early on in that hyperphase.
You'd expect things like a racing heart, palpitations, feeling unusually warm or sweaty, maybe unexplained weight loss, shaky hands, feeling anxious or irritable.
All signs of the body being in overdrive from too much hormone.
And then later, if it flips into the hypothyroid phase,
It's the opposite, right?
pretty much fatigue, maybe significant fatigue, weight gain, feeling cold when others aren't, maybe constipation, even feeling down or depressed.
Classic signs of the system slowing down.
Right.
And if a doctor examines someone during this, what would they typically find just by, feeling the neck?
The sources say the thyroid gland itself usually feels tender when touched
Okay, sore.
and often feels firm, maybe a bit rubbery and enlarged. Sometimes it's asymmetric, meaning one side feels bigger than the other.
And there was a really important point in the notes about what isn't usually found. Something about lymph nodes.
Yes. Crucially, there's typically no significant lymph node swelling, no lymphadenopathy nearby.
And why is that absence so important?
Because if you had, say, a bacterial infection causing that kind of neck pain and swelling, you'd almost always expect to find swollen, tender lymph nodes in the area as the body fights the bacteria.
So the lack of swollen nodes helps point away from a bacterial cause and more towards something like SAT.
Exactly. It's a key differentiating sign.
So really the whole collection of symptoms and signs, the pain, the fever, the hyper-hypo swings, the tender gland without swollen nodes, it all paints a picture reflecting that underlying process.
It does. It's the body showing you externally what's happening internally, that immune-mediated inflammation, the hormone release, and then the depletion.
Okay, makes sense. So how do doctors confirm it? What are the key diagnostic tests mentioned in your sources?
Lab tests are absolutely essential here.
Right. What are they looking for?
Well, thyroid function tests first. TSH, thyroid stimulating hormone. Initially, in that hyperphase, it'll be low, suppressed.
Because there's already too much thyroid hormone floating around.
Exactly. And free T4, the active thyroid hormone, will initially be high.
And then later, in the hypophase.
They'll flip. TSH will become high as the pituitary gland tries to stimulate the underactive thyroid, and free T4 will be low.
Okay, that reflects the phases. But what else? There was something mentioned as a very strong indicator. ESR.
Yes, the ESR, erythrocyte sedimentation rate. Your sources really emphasize this one. It's typically markedly elevated,
How high are we talking?
often greater than 50 millimeters per hour, sometimes even over 100. It's a nonspecific marker of inflammation, but such a high level in this context is very suggestive of SAT.
Okay, so really high ESR is a big red
A
flag.
very big one. Elevated CRP, C-reactive protein, is also common for the same reason, systemic inflammation.
Right. And what about thyroid antibodies, like the ones in Hashimoto's or Graves'?
That's another key point. In subacute thyroiditis, those specific thyroid antibodies like anti-TPO or antithyroglobulin are typically negative or may be present only at very low levels.
And testing for those helps rule out those other conditions.
Precisely. High levels of those antibodies would point strongly towards autoimmune thyroid diseases like Hashimoto's or a Graves' disease, not SAT. So their absence is important diagnostically.
Got it. What about imaging? Does an ultrasound help?
It can, yes. A thyroid ultrasound in SAT often shows the gland looking hypoechoic, which means it appears darker than normal tissue on the scan.
Okay.
And heterogeneous, meaning the texture looks patchy or irregular. And another really useful finding on ultrasound, if they use Doppler,
What's that?
Doppler ultrasound looks at blood flow. In SAT, there's typically decreased or absent blood flow within the inflamed thyroid tissue.
And how does that help Distinguish it.
Because in Graves' disease, another common cause of hyperthyroidism, you usually see markedly increased blood flow, sometimes called a thyroid inferno. So seeing low flow argues against Graves and supports SAT.
Interesting contrast. And there was one more key test mentioned quite prominently, RAIU.
Yes, the radioactive iodine uptake scan. This is often very helpful in sorting things out.
What does it show in SAT?
It shows decreased uptake, very low uptake, in fact,
Why is that?
because those thyroid follicles are inflamed and damaged. They're not functioning properly, so they can't effectively trap the radioactive iodine tracer that the person is given for the test.
And that's different from other causes of hyperthyroidism.
Very different. In conditions where the thyroid is overproducing hormone, like Graves' disease, the RAIU is typically high because the overactive cells are grabbing lots of iodine.
So that combination seems really powerful diagnostically. The symptoms, the really high ESR, the low RAIU, and the negative antibodies.
Exactly. That pattern is highly characteristic of subacute thyroiditis and helps differentiate it clearly from other possibilities like acute bacterial thyroiditis, Graves, or Hashimoto's.
Okay, that makes sense. So once the diagnosis is pretty clear, how is SAT actually treated? What do the sources say about management?
The main thrust of treatment, according to the sources, is managing the symptoms. It's supportive care.
Because it's self-limiting, right? It gets better on its own eventually.
Precisely. The goal isn't really to cure it in the traditional sense, but to make the person comfortable while the inflammation runs its course and the thyroid heals.
So dealing with that major symptom, the pain and inflammation, what's used?
For mild to moderate pain, standard NSAIDs, non-steroidal anti-inflammatory drugs like ibuprofen or sometimes aspirin can be enough.
Okay. But what if the pain is really severe?
Then corticosteroids are usually needed. Prednisone is the common one.
Steroids, okay. How do they help?
They are potent anti-inflammatories. They work quickly to dampen down that immune-mediated inflammation in the thyroid, which significantly reduces both the pain and the swelling. The typical starting dose mentioned is around 20–40 milligrams per day.
And that usually brings pretty rapid relief for the pain.
Often, yes. Then it's usually tapered down slowly over several weeks as the condition improves.
Okay. What about managing those temporary hyperthyroid symptoms, like the racing heart or tremors?
For those symptoms, beta blockers are the go-to, drugs like propranolol.
And they work, but
They don't affect the thyroid hormone levels themselves, but they block the effects of the excess adrenaline that's stimulated by the high thyroid hormone. So they slow the heart rate, reduce tremors, help with anxiety. They manage the symptoms of the hyperthyroidism.
got it. And the sources had a really strong warning about not using certain drugs.
Yes, absolutely critical point. Antithyroid drugs like methimazole or PTU should not be used.
Why not? They're used for other types of hyperthyroidism, aren't they?
They are, but those drugs work by blocking the production of new thyroid hormone in the gland. In SAT, the hyperthyroidism isn't caused by overproduction. It's caused by the leakage of preformed stored hormone from the damaged follicles.
Ah, so the antithyroid drugs wouldn't stop the leakage.
Exactly. They have no role, they won't help, and they just add potential side effects. It's a really important distinction. SAT is a destructive process, not an overproduction process initially.
That makes total sense. You're managing the fallout from the damage, not trying to shut down a factory that's working overtime.
That's a perfect analogy.
What about later, if someone enters that hypothyroid phase? Is treatment needed then?
It depends. If the hypothyroidism is mild and not causing significant symptoms, sometimes doctors just monitor it. But if it is symptomatic,
Like causing fatigue or other issues?
yes. Then levothyroxine, which is just synthetic T4 hormone, is usually prescribed to replace the missing hormone and alleviate those symptoms.
But that's also usually temporary.
Often, yes. As the thyroid recovers, the levothyroxine dose can typically be reduced and eventually stopped in most people.
So summing up the treatment, it's really about symptom control. Pain relief with NSAIDs or steroids, symptom relief for the hyperphase with beta blockers, and maybe temporary hormone replacement for the hypophase if needed, all while letting the body heal itself.
That's the essence of it, a supportive strategy while the self-limiting process unfolds.
Okay. Looking towards the end of that process, what's the general outlook?
The prognosis?
The good news, and your sources consistently state this, is that the prognosis is generally excellent. Most people recover completely. That's reassuring, especially given how rough the initial symptoms sound. How long does recovery usually take?
The typical time frame mentioned is somewhere between 3 to 6 months for full resolution and return to normal thyroid function.
Are there any potential bumps in the road? Any complications mentioned?
They are generally uncommon, But yes, recurrence is one possibility. The thyroiditis coming back later,
Hmm.
but the sources say this is rare.
Okay, what else?
The main thing to be aware of is the potential for permanent hypothyroidism.
Ah, so the thyroid doesn't fully recover its function in
In
everyone.
a small percentage of people, yes. The estimates in your notes suggest maybe 5 to 10% of cases might end up with lasting hypothyroidism after the inflammation resolves.
And if that happens.
Then they would need long-term treatment with levothyroxine, just like anyone else with primary hypothyroidism.
Okay, so permanent hypo is uncommon, but possible. Anything else?
Right.
Anything really acute or dangerous?
Thyroid storm, a severe, life-threatening surge of thyroid hormone, is listed as a theoretical, very rare complication from that initial massive hormone release.
Yeah,
But again, the emphasis is on very rare in the context of SAT.
understood.